The next topic is management of acute cerebral sinus venous thrombosis. I'll request chairpersons Dr. Neetu Ram Rakhani ma'am and Dr. J.C. Malu sir. Please come on the stage. And I will request Dr. Grees V. Kulkarni sir for the talk. Dr. Tarachand Joshi, please come on the stage to welcome all the chairpersons and the speakers. Dr. Neetu Ram Lakhani ma'am is a director of neurology in Fortis Hospital, Jaipur, and Dr. J.C. Malu sir.
Director at Manidhari Hospital, Jodhpur.
Dr. Girish Babu Kulkarni. He is a professor of neurology at NIMHANS, Bangalore, and he has more than 20 years of experience. His areas of interest are headache, stroke, and quality in healthcare. So I would request you to present your topic in this conference.
Thank you, ma'am. At the outset, I thank Dr. Suresh Gupta ji and all the members of the Eternal Hospital for making such a very nice program and impressive speakers. And I also thank Dr. Tarachand Joshi for inviting me. And it has been a pleasant time listening to all the speakers regarding various aspects of the arterial stroke. Now, I know that I am between you and the lunch, but I will try to make it very interesting for you to manage this type of stroke. So, greetings from NIMHANS, Bangalore. Now, all of you have heard about ischemic stroke, and probably whole world it is a very common and most talked stroke. But venous stroke has around 10% possibly in India, and more so in some of the countries, and more so in the younger population. So this is the very important aspect compared to the arterial stroke. Then second important thing is the diagnosis, the various risk factors, and the management totally differs from the arterial stroke. Now, compared to the arterial stroke, where the symptoms are sudden, happening immediately, here the symptoms are not very sudden. They are predominantly gradual, and sometimes it may be non-specific. So everything depends upon the sinus vein which is involved, the anastomosis which are present, and time of development of this thrombus. Broadly, if you see, these are the 5 different headings under which venous stroke comes. And it's a guess that you can always see. If it is a chronic, slowly progressive, probably lateral sinus, isolated rise density. If it is a focal acute presentation, focal deficit, deep sinus encephalopathy, very slowly progressive lateral sinus, presents with lower cranial nerve palsy, and cavernous sinus has a very characteristic clinical presentation. Now, the various symptoms present in this CVT are headache, seizures, motor weakness, altered sensorium, and impairment. Now, the common risk factors, as all of you have experienced, are totally different in males and females. In females, it is predominantly anemia, puerperal state, OCP. In men, especially in our center, we see large number of alcoholic polycythemia and hyperhomocystinemia. The probably the presence of progenetic or procoagulant states are maybe less curiously also, because we are not explored in the majority. Some patients definitely APLA comes positive. Now, if you see the overall picture of treatment of CVT, all patients require acute treatment with anticoagulation, maintenance treatment with anticoagulation. Some patients require antiedema. All patients again require management of the risk factors, and few requires very specific treatments which are required and which requires probably a careful decision. Now, why it is challenging to manage CVT? Because it is a rare, it presents in multiple ways, it is presents to multiple specialties also, varied risk factors, difficulty in interpretation imaging, especially only if sinus is involved or only hemorrhagic lesion is there, and we are treating a heparin in the presence of bleed in the brain. Now, anticoagulation among all the treatment aspect of CVT forms the most important and a cornerstone of management of the CVT. Challenges with venous stroke anticoagulation is enormous and thought-provoking. Now, in our day-to-day practice at NIMHANS, and all of us, we face all these challenges. I thought that these are the challenges, and I will present my talk in such a way that you are convinced how we are going to manage. Now, we are treating a patient in the presence of hemorrhage in the brain, and can anticoagulation can be given? From what data we are telling that anticoagulation can be given? If so, whether it's unfractionated heparin, which is easily available but requires a lot of efforts to give the treatment, low molecular weight heparin, especially in a hospital like NIMHANS, where majority of the poor people come, where they can afford, and what should be the dose, what should be the duration? We have a patient, around 4 to 10% of the patient, who is waiting, probably he will develop herniation, whether I can give this anticoagulation before surgery or what. We have done the surgery now, whether we can give the anticoagulation and at what time. We have a patient, 3 to 6 months, who has improved, but still there is no recanalization, whether anticoagulation to be continued. We have a patient who is having CVT, unfortunately develops the pulmonary embolism also. What next to do? And we have a, very rarely we get a pregnant lady in the first trimester comes with vomiting, and we have multiple differential diagnosis. We can't do all investigation. MRI brain plane you do, and you diagnose a case of CVT. And the most important now, after speaking to all my previous, listening to all of our previous speakers, well-preserved CVT patient who has come to our OPD, whether I can directly start DOACs or NOACs, as was discussed, and a lady with CVT with menorrhagia with anemia, how to go about anticoagulation in this patient. So these are all the various aspects of anticoagulation. I thought that I will put forward the various data. And finally, no conference is full without speaking about the effect of COVID and anticoagulation and vaccine. Now, one question arises in all our minds: where to manage this patient? The general Cochrane review has come out that all patients of stroke, irrespective of the time, are better outcome in a stroke unit. We all know that there are various methods of stroke unit definition. Probably all will help. And probably we require additional help of a hematologist or a obstetrician in a given patient, depending upon the situation and the patient. Now, the treatment of anticoagulation in CVT depends on our understanding of Virchow's triad, where it is stasis and endothelial injury, which are more common in the leg veins, and probably we are dealing with the hypercoagulability. Very rarely, like infections and other conditions where endothelial injury is there, so we come across as a risk factor. Now, all of us as a clinician should know that there are two pathways and one common pathway, and we should know that vitamin K antagonists act on 2, 7, 9, 10, and there are direct thrombin inhibitors, and there are factor 10A inhibitors. So if we have a gross idea of this pathway, which helps us to choose the anticoagulant which we can choose. Then after knowing this, how to initiate by choosing a agent, maintenance of the anticoagulation, and decide the duration. These are the three questions we should ask. The most important aspect of CVT management, what I have realized over years, is risk factor management prevents the further progression. So all the risk factors in a given patient, whenever he is admitted on day one, should be quantified and tackled. Now, this is the various anticoagulants and their age, because previous speaker also have covered. I will skip. And there are excellent, very interesting stories on discoveries of these anticoagulants. Whenever you get a time, please go through that. Now, basically, we are left with three things: heparin, conventional oral anticoagulants, and NOACs or DOACs. Now, how these act and what is the importance of differentiation? All of us should know that unfractionated heparin acts against factor 10A and thrombin through involvement of the antithrombin, and low molecular weight heparin has a greater activity with 10A. Now, vitamin K antagonists have predominantly role in reducing and oxidization of the vitamin K dependent factors of 2, 7, 9, 10. So it acts by that. Now, if you compare the two VKAs agents, there are some differences. I think there is a difference in various parts of the country. Some centers using warfarin and some centers using acenocumarol, and probably whichever we are confident and we are having experience, we should continue. But the important thing is what I have realized in NIMHANS practice is we prefer acenocumarol because of this reason. Now, once we decide that anticoagulation, why we should start anticoagulation in a CVT? The important things are, it is prevent the thrombus growth to facilitate the recanalization, and lower limb thrombosis and pulmonary embolism can be prevented. These are the three important reasons why anticoagulation should be done. And the fear is many patients, almost around 40 to 60% have a hemorrhage. So that fear, whether I will aggravate the hemorrhage is the question. Then why we should start with heparin and go for oral anticoagulants? Because we require a predictable action, titration is required, and procoagulant action of VKA, because it will also affect the protein C, protein S. So there will be a paradoxical procoagulant. If you start with the vitamin K antagonist, you should start with heparin. Now, there are two routes of heparin, IV and subcutaneous. Now, IV, the problem with low molecular, IV with unfractionated heparin is you have to do continuous monitoring of the APTT, which is very difficult in any hospital setting. Now, subcutaneous, it is easily given. We give both unfractionated and low molecular weight in subcutaneous route only. The problem with subcutaneous heparin is very rarely people may object to the staining that may happen, but otherwise majority of the things are taken care. And then there is a doubt whether the pharmacokinetics and dynamics, whether it will change. So these are the challenges with the subcutaneous. Now, you will be wondering on what basis this all IV heparin has been started. And you will be surprised to know in literature, there are only 3 randomized controlled trials. And the number of the patients involved in these randomized controls are very, very less. So the first randomized control trial, which started from ANPOL, they had only 20 patients of CVT randomized to 10 each in heparin and placebo IV. And you can see in the heparin group, almost everybody is improving. And in placebo, many are not improving, and some people have died and some are mildly improving. And there are a lot of drawbacks and pros and cons. Whenever you get a time, please read. But the important thing is this was the first randomized controlled trial. Then the second randomized controlled trial in the literature is from our institute by our teacher, Professor D. Nagaraja. He did a patient's group of purpural CVT with no parenchymal lesion, and they also showed that there is better recovery with the treatment. Then subsequently, there is a trial of low molecular weight heparin compared to the placebo, and in that also they showed that the recovery is best. Then finally, there is a Cochrane review which tells that it is beneficial, the IV or subcutaneous low molecular heparin. Now, any studies that you will be wondering, okay, now there are some studies to tell that heparin is helpful even in the presence of hemorrhage. Now, any study is there to compare unfractionated heparin versus low molecular weight, and this study is there from our India only. Dr. Mishra sir and madam have done, and they have shown that low molecular weight heparin has significantly lower hospital mortality compared to CVST. Then there are some large observational studies from ISCVT. They also show that low molecular weight has a better efficacy over the unfractionated heparin. Now, problems with IV heparin I already have told, and low molecular weight already told. Now, in NIMHANS, we see lot of patients. Almost every day, one patient is admitted to our stroke ward. So, what we realized is at our center started from Professor D. Nagaraja, and as time goes on, Virendra Kumar sir and others have contributed. We have devised a useful and highly efficacious treatment at our center. what we do is we use subcutaneous unfractionated heparin, 5,000 units subcutaneously 6 hourly for the 10 days. On 7th day, we start the oral anticoagulant, usually asanequimurol, 4 mg stat, and then 8th day 3 mg, and then subsequently 2 mg we maintain. We check APTT, PT, and platelets on day 0, 5, 13, and platelets on 7. And then weekly platelets are done and discharged in the monthly ones, and we keep PTINR at around 1.5 to 2. If you go through all this now, and what are the current guidelines are there in the anticoagulation? There are AHA, ASA guidelines, and then European guidelines, and whatever has been discussed now, it goes in that way. That is, probably you require a parenteral anticoagulation initially, and vitamin K antagonist later on. And European guidelines specifically tell that subcutaneous low molecular heparin may be preferred. Now, both the guidelines tell that unlikely that any more randomized control trials will come in CVT. Now, once we are done with parenteral heparin followed by oral anticoagulants, next step is how long to treat the patient. So now it is probably the prevention of the recurrence of the CVT, and also the risk of recurrence because of the underlying the risk factor. So that is the importance of knowing the risk factor, and very rarely we may have a lower limb venous thrombosis also. So the rule of thumb is, like at NIMHANS also, what we do is we give, majority of the patients are postpartum or OCP, where we know that these are the reversible and transient causes. So we give them treatment 3 to 6 months. And after 6 months, again, I will check homocysteine and hemogram. If everything is normal, we stop the anticoagulation. And after 2 months, we repeat the protein C. We do the protein C, protein S, antithrombin, factor V mutation, and antiphospholipid antibodies. If everything is normal, we will not continue anticoagulation. If no cause is found, male patient is there, no risk factors are easily definable, we continue anticoagulation for minimum 1 year, and again we do all that whatever I told for the thing. Supposing a patient comes with recurrent CVT, or a patient has a protein C, protein S, or factor V Leiden mutation, invariably I will have a discussion with the hematologist in another hospital, and then continue after explaining the risks and benefits of the anticoagulation to the patient, probably a long time or lifelong. Now, all of us are enthusiastic by the recent developments in the development of the NOACs. Now, it has been listed what are the advantages of NOACs, so I will not go to that. The important thing what I want you to remember is, because majority of the trials are using rivaroxaban, the food intake and intake with the food is the most important thing. And as Dr. Atul was explaining regarding the creatinine clearance, age, other important things we have to consider. Now, there are 2 randomized control trials in the field of NOACs in CVT, and there are 2 recent meta-analysis systematic review. The summarizing all this, this is the first study, which is called a RESPECT, where they compared the warfarin with dabigatran. The second one was Einstein Junior trial in a CVT patients in children. They compared. Rivaroxaban has been compared. And there are 2 systematic reviews which are recently published. And what is the whole idea from these trials and systematic review is, in a patient with CVT who is probably milder, and probably all these studies and trials have given initial heparin, low molecular weight or subcutaneous, followed by this oral anticoagulant. And they have found that in almost all patients, there is no difference in the recanalization, death, and morbidity. So these are the important things. But we have to keep in mind that all these studies are having some issues. What are these issues? The data is limited, and majority of the data is from the observational studies. The patient selection in majority of these trials is those who are well preserved and less severe. They have been assessed. And initial anticoagulation is parenteral rather than oral. And whenever you feel that there may be an issue of reversibility will come into the picture, especially in an unstable patient, a large hemorrhagic infarct, probably we can will not give the agent, because reversibility is difficult in all settings possibly and all the agent. And there are some reports that in APLS syndrome, the NOACs may not be helpful, and it may be harmful also. So these are the issues you please consider whenever you decide regarding the initiation of the NOACs in CVT. The another important aspect, especially in a hospital like NIMHANS, is the cost of the medicine. That also you can calculate depending upon the available brands in your place. Now, the other various situations I talked about in case of CVT are pregnancy, surgery, and recanalization and anticoagulation duration. Now, pregnancy, majority of the patients, whatever we have seen, are in the first trimester. They come, as I told, with vomiting, headache, and MRI brain plane we do and we discover. So initially we give heparin, and we continue on low molecular weight heparin, and we undertake a referral letter to the local obstetrician for the thing. In the literature, it has been told that during the second trimester, you can give the warfarin also, but we have never tried that method. And there should be a good coordination with the person who is managing her pregnancy and the neurologist. And during the surgery, probably a continuous dialogue is required. Regarding surgery and stopping and restarting in a decompressive surgery, luckily the number of patients who will be facing is very less. Hardly 4 to 5% of the patients of CVT undergo surgery. So what we do is, because we are giving low molecular weight, will not be giving a low molecular weight in NIMHANS. We give only subcutaneous heparin. We check the platelet FETT before surgery and stop the thing. And depending upon the time and we calculate, if required, protamine we give. After surgery, there are no studies. There are usually depends on the prevention of the DVT in the leg and removal of the usual drain. In NIMHANS, majority of the surgeons put the drain. So what we do is, once the patient undergoes surgery, he will come back to our stroke ward. We continue only 2,500 BD of heparin. That is almost 1/4 of the dose of heparin given every day. And once they remove the drain, we escalate the heparin from next day onwards. Regarding recanalization and anticoagulation, there are various studies looking into anticoagulation, recanalization rate, time, and CVT. So what they have found out is, partial recanalization is very common, and in 8th day, 30th day, and 3 months they have looked into, and you will be amazed that almost 70% of the patients will have a partial recanalization by 8 days. So by 90 days, majority will have a recanalization. And in all our practice, we have never seen anybody recurring unless some underlying factors are there. So usually we will not take recanalization to our consideration deciding the duration of the anticoagulation. Now, the recent development of the COVID-19, some issues have come out, and initial reports, there were a lot of thinking regarding the procoagulant state of affecting the legs, pulmonary embolism, and the CVT. And if you see the literature, there is a gradual shift of the thing because of the presence of availability of vaccine also. And they feel that in compared to the usual routine demographic profile of CVT we see in general ward, CVT in a COVID patient usually involves the elderly people and more severe and more associated with that, around 16 to 20% death compared to the routine group of CVT patient, around 5 to 10% will die. Then another important thing is the vaccine associated thrombotic events. The important thing is we cannot use heparin in them, and all of us should be aware that whenever we get a CVT patient during our time nowadays, always we should ask whether this patient has received vaccine or whether he has developed any COVID-like symptoms. Why? Because we have to give either Novax or Fondaparinux in association with immunoglobulin treatment. So this vaccine-associated VITT is usually seen with our AstraZeneca and also in Johnson & Johnson, and there are few reports with mRNA also. Now, after knowing about all the details about the anticoagulation, now finally 1 or 2 slides how CVT is being treated by anticoagulation from various people around the world. And this study is probably 1 decade old, and it involves various physicians and various specialties with various experiences, and with many of them having very good experience. And as you know, almost what we do in our day-to-day practice is being done in majority of the patient. Some difference is there in the agreement of the various aspects of the treatment of the CVT. So, in conclusion, CVT is a rare form of stroke presenting with diverse symptoms and severity with a very good long-term outcome if acute care is good. The guidelines from AHA, ASA and EFNS on acute anticoagulation are based on few randomized studies. It is unlikely that newer RCTs will be done in acute anticoagulation in CVT. Anticoagulation has helped to reduce the mortality from 50% to 5%. And IV and subcutaneous anticoagulation followed by oral is the regimen of choice. The effectiveness and safety and economics of newer agents in the future of the anticoagulation, probably in another 5 to 10 years, definitely, we will have better knowledge about this. And this is the treatment algorithm. All of us we know. Initiate with subcutaneous or low molecular weight heparin or IV heparin. Then if patient is stable, continue the anticoagulation with oral anticoagulation. Depending upon the risk factors, you continue for 3 to 12 months or lifelong. In case of any worsening, either surgery or whether any other treatment which are emerging, you have to decide. So thank you.
Thank you very much, Dr. Kulkarni, for a nice compilation and being within time for a difficult topic, and you have covered it nicely, especially emphasizing the oral anticoagulation. Yes. Thank you very much. I think my
Thank
time
you,
for
sir.
lunch now.
Yeah, I will request Dr. Neetu ma'am and Dr. Mathur, please present a
Thank you
moment
once
for
again.
Dr. Girish.
Hello, ma'am. Yes, ma'am. Thank you, ma'am.
Thank you. Now